Good afternoon, and thank you all for joining us for the release of BPC's policy recommendations that are designed to guarantee fully integrated care for Medicare and Medicaid beneficiaries, commonly referred to as, of course, the dual eligible population. I'm Bill Hoagland. I have the pleasure of working with our health team here at BPC. When Medicare and Medicaid services are not integrated, dual eligible individuals find themselves navigating separate programs to receive health care, long-term services, and supports and other services. There's estimated to be a little over 12 million people qualifying for both Medicare and Medicaid, many with physical or developmental disabilities. And that current system makes it extremely difficult for healthcare providers to deliver the care to patient-centered care. And it is increasingly difficult to provide challenges for beneficiaries and their families to navigate care, appeal a coverage decision, or determine who can get help. I understand in extreme cases, a dual eligible individual could be enrolled in up to as many as 5 separate programs. The report BPC is releasing today builds upon recommendations from an earlier 2020 report that we made. In that earlier report, BPC first recommended that Congress established a full integration standard and an incentive for states to take the lead in integrating care for dual eligible individuals by a certain date. BPC recommends that these incentives include financial and technical assistance to help state plans develop and implement fully integrated models. Today's BPC report incorporates and expands on that earlier set of recommendations, and to target provide a targeted framework for advancing fully integrated care for Medicare and Medicaid individuals. On behalf of BPC, I want to thank the Arnold Ventures for their support of today's report and this event. And before I turn this over to Arlie Meir with the Arnold Ventures, a few remarks, a final, I guess, very sad set of announcements. Catherine Hayes, our Director of Health Policy, who will you'll hear from here shortly to provide more details on this set of recommendations, is retiring on December the 1st. She's been a longtime friend and colleague of mine going back to our earlier days as fellow staffers in the United States Senate, where she served both Republicans and Democrats, members of Congress. We had the good fortune of joining back up here together at BPC nearly a decade ago, where she has led our health policy work with intelligence, grace, and objectivity. I know no one else who understands the intricacies of Medicare and Medicaid, both professionally and has had to live the issues personally, as well as Catherine has. We will all miss her here at BPC. I will miss her, but wish her a much-deserved respite from the challenges that continue to confront our healthcare system today. But I am also comforted by knowing that that system would be even more challenging today had it not been for the advice and work Catherine has given to policymakers over the past many years to improve that system. And fortunately, many of those policymakers have had the good sense to follow her advice. So now let me introduce Arlie Meir with Arnold Ventures for her opening remarks. Arlie?
Thank you so much, Bill. I'm Ariel Meir, and I'm the Vice President of our Complex Care Program on the healthcare team at the Philanthropy Arnold Ventures. Our work is motivated by a deep concern about the affordability of the US healthcare system, where we pay too much and have not enough to show for it. And nowhere is that more true than for the 12 million people who are dually eligible for Medicare and Medicaid. Convoluted systems that don't work together, or frankly, work at cross purposes, leave low-income older adults and people with disabilities at risk. It leads to more hospitalizations and nursing home stays, poor health, and high spending. Integrated models that bring Medicare and Medicaid together in one seamless person-centered delivery system have the potential to change that. They can also be a platform for a radical reorientation of our system away from one oriented solely to the treatment of disease and response to acute issues to one that values health, independence, and dignity for all people. There's a lot in this report, and rightly so. There's a lot to be done. But if there's one thing I want to elevate and celebrate is this report's bold and visionary statement that every person who is dual eligible in this country should be guaranteed access to an integrated Medicare-Medicaid option. Incentives, strong incentives to states to develop and implement an integrated option, combined with a federal fallback for states that opt not to, is one way to achieve this aim. Thank you to BPC for carrying this banner and for assembling today's terrific panel. Success here depends on having strong consumer voices, forward-looking health plans and accountable provider systems, and imaginative and committed policymakers at the state and federal level. And I look forward to the conversation. So thank you all for coming today, and in particular to the BPC advisors and staff who led this work and all the individuals who gave their expertise to shape this report. And thank you in particular to Catherine, who has been a lightkeeper for this work at BPC and throughout her career. Over to you, Catherine.
Thank you very much. Thank you, Bill, too, for your kind words. It's been a privilege to work with you and a privilege to work at BPC. I'd like to do a quick overview of our recommendations. Very generally, as Ariel mentioned, the intent here is to guarantee access to a fully integrated plan to all Medicare and Medicaid beneficiaries, also known as dual eligibles. Our recommendations would do this in 4 ways. 1, better defining integration. 2, providing assistance and incentives to states to integrate Medicare and Medicaid. 3, improving beneficiary experience and beneficiary protections. And 4, providing a federal fallback in the case of states that choose not to integrate care. These recommendations define full integration as a single entity responsible for providing all Medicare and Medicaid services, both in terms of delivery of care and in financing. This would include behavioral health and long-term services and supports, benefits, which are often carved out of some of these plans. It would include a single enrollment period, a single set of informational and educational materials for beneficiaries, a single point of contact, and a single unified grievance and appeals process for plans or provider groups. The assistance and incentives to states would include, first of all, the establishment of a regulatory framework. And that was one of the things that we really heard from states on is, just tell us, just give us a framework for integrating care if you want us to do that. Don't ask us to sit down and try to figure out from scratch what we want to do. So we indicated that they would include a fully integrated Medicare Advantage duals special needs plan, the program of all-inclusive care for the elderly, and a managed fee-for-service model similar to Washington State's Medicaid Health Home. We also recommend providing general waiver authority to the Secretary to align the 2 programs, similar to the authority that was provided under the financial alignment demonstration. In addition to the regulatory framework, we'd provide help to states in the form of technical assistance and financial resources to set up these integrated care models. And we recognize that there are some states that have little experience in integrating Medicare and Medicaid services, and they will need time to do that. And also we would include guaranteed shared savings. So if there is Medicare savings through reduced hospital admissions, readmissions, emergency departments, or lower cost post-acute care, states would receive a portion of those savings. The beneficiary protections would include, while we would allow states to implement passive enrollment, there would be a beneficiary opt-out if they or a family caregiver aren't happy with the care that they get. No beneficiary would be required to get their Medicare through an integrated care model, but they would have the option if they chose to do so. We would direct the Secretary to require collaboration between the Center for Medicare and Medicaid Services and the Administration for Community Living and states to implement model standards for outreach and education, and increase funding to the State Health Insurance Assistance Program to expand and improve information and counseling services available for dual eligible individuals. It would also provide additional resources and technical assistance to states for consumer, provider, and plan engagement and education, and encourage states to prioritize partnerships with community-based organizations and local governments. It would also direct the Secretary to improve training for insurance brokers by including a training module on fully integrated plans. Finally, for the most controversial aspect of this proposal, we believe that states are in the best position to contract for Medicaid services, and we're hopeful that the new regulatory framework, the technical assistance, the funding, and the guaranteed shared savings will move all states forward. However, states should not be an obstacle to integrated care. So if they do not move forward, our recommendations direct the Secretary of HHS to contract with plans or other provider organizations to integrate Medicare and Medicaid services at the federal level. This would also include a hybrid model for states that want to be responsible for certain functions, such as assuring network adequacy. I'd like to thank you very much and recognize Lisa Haratunian to introduce the panel.
Thank you, Catherine, and thank you to everyone for tuning in today. My name is Lisa Haratunian, and I'm an Associate Director for the Health Program at BPC. Today, I'm joined by 4 panelists who together bring a range of perspectives and valuable expertise to our discussion on integrating care for individuals with Medicare and Medicaid. Through the lens of their federal, state, consumer, and plan perspectives, our panelists will help us understand who dual eligible individuals are, what fully integrated care means and why it's important, as well as some of the challenges and opportunities to guarantee integrated care for Medicare and Medicaid beneficiaries. First, I'll introduce each of our panelists, and then we'll dive into some questions. At the end, we will also address some audience questions. So I strongly encourage all of our viewers to submit their own questions throughout the panel discussion using live chat on YouTube or on Twitter by using #BPCLive. So the first panelist I would love to introduce and welcome is Tim Engelhardt. Tim directs the CMS Medicare-Medicaid Coordination Office, which is dedicated to improving services for individuals dually eligible for Medicare and Medicaid. Prior to joining CMS in 2010, Tim was a consultant with the Lewin Group, and he previously served as the Deputy Director for Long-Term Care Financing at the Maryland Department of Health and Mental Hygiene. Next, I would like to welcome Lena Sharma. Lena currently serves as a Senior Policy Analyst with Community Catalyst. In this role, Lena provides policy expertise by translating knowledge and policies to support advocacy that promotes consumer and community engagement in health system transformation. Lena also serves as the lead for the center's efforts to improve care for Medicare-Medicaid beneficiaries and is responsible for integrating lessons from this work into the broader work of the center. Prior to this role, Lena served as the Senior State Advocacy Manager on the Voices for Better Health project. Next, I would like to welcome Pam Parker. Pam currently serves as a Medicare-Medicaid integration consultant with the SNP Alliance. Pam has over 34 years of experience in state government in Minnesota. She was responsible for the creation of the first CMS-approved state Medicare-Medicaid integration demonstration. She also developed and managed several specialized managed care programs for seniors and people with disabilities, as well as the first Medicare-Medicaid DSNP demonstration approved by CMS in 2013. Pam served as Director of the Long-Term Care and has a long history of consumer advocacy, serving as the state's first long-term care ombudsman. Finally, I would like to welcome Alexandra Cruz. Alexandra is the Associate Director for Integrated Care and State Programs at the Center for Healthcare Strategies. She focuses on initiatives related to reforming state long-term services and support systems and integrating care for individuals duly enrolled in Medicare and Medicaid. Alexandra spent 7 years working on Medicaid LTSS programs and policy development in Florida, where she served as chief for the Nursing Home and HCBS Eligibility and Pre-Admission Screening Bureau, and also directed Florida State Health Insurance Assistance Program. She began her career in California, working as a provider of nursing facility and assisted living services. So thank you to each of our panelists for joining us today. I think it would be great to start our discussion by talking about who dually eligible individuals are. So this first question is for Tim. We know that there are about 12.2 million dually eligible individuals, and that this is an extremely heterogeneous population. These individuals become dually eligible through a variety of enrollment pathways, and some may also be full or partial benefit dually eligible beneficiaries. So Tim, what are some of the characteristics of the dually eligible population? What do we know about the population? And would you please describe the difference between full and partial benefit dually eligible individuals?
It's a diverse and dynamic population. The shared characteristic of being enrolled in both of Medicare and Medicaid, and there's primarily low-income older adults and people with disabilities. Important to remember that they cross the full range of ages. Almost 40% of dually eligible beneficiaries are under the age of 65, and they're eligible for the programs based largely on the fact that they either have physical disability, serious and persistent mental illness, or an intellectual developmental disability. It's also, you asked about full versus partial benefit dually eligible individuals. About 70% of what we call full dually eligible individuals, and that means they're eligible for the full suite of Medicaid benefits, whereas partial benefit dually eligible individuals only have Medicaid coverage for their Medicare cost sharing. So the state Medicaid agency covers their Part B premiums, cost sharing for and deductibles and other forms of cost sharing that they may experience. About half of the dually eligible population uses long-term care services. Over 40% has a mental health diagnosis, a very high rate of chronic conditions and multiple chronic conditions, and is racially and ethnically more diverse than the rest of the Medicare program. Almost half of dually eligible individuals are from a racial or ethnic minority group.
Thank you. Thank you so much for sharing that. Now that we have a better sense of who the dually eligible population is, let's talk a little bit about what we mean by fully integrated care. We heard remarks earlier from Bill Hoagland and Catherine Hayes about how Medicare and Medicaid beneficiaries must often navigate separate programs and how BPC recommends establishing a full integration standard. So let's talk about what that means. Pam, I'd like to turn to you. And if you could please describe, what does it mean to fully integrate Medicare and Medicaid?
Well, thanks, Lisa. I think one issue that we have is sometimes we think about how we have to merge the financing of these two programs somehow, and that is important, but we must go way beyond that to merge the care delivery and make sure that the consumer has a fully coordinated, person-centered care delivery system that moves across providers, across settings, and simplifies access to the full range of services for those individuals, including, the operational background work that has to be done in order to simplify things for people. So that's what we in the SNP Alliance have pushed for. We have a couple of documents on our website, www.snipalliance.org, that talk about our criteria for what we believe true integration, how it needs to be evaluated, and also how just the overall, a brief about integration and what that means in a broader context.
Thank you. So Alexandra, on the same note, what does fully integrated care look like from the state perspective, and what should the goal of integration be?
That's a great question. And I think from the state perspective, building off of what Pam was sharing, there is, and Tim as well, there's a significant awareness of the intersection between the Medicaid benefits and services that full benefit dually eligible individuals need on a daily basis to, make their lives work, make their lives possible based on limitations that could be driven by LTSS needs, complex behavioral health needs, as well as the chronic conditions that, the Medicare side of the equation is generally charged to support. And I think when we think about full integration from the state perspective, it's really about how you bring those things together to have a care management model within an integrated program, whatever that program looks like, whether that's a managed care delivery system, which is perhaps most often used by states these days and increasingly used by states to serve LTSS and behavioral health populations. There's that intersection of a care management model at the plan level or at a provider level, where states have decided to try to integrate benefits and services in a fee-for-service setting. And I think when you think about the state perspective, that there's a definite interest in the experience of care of that individual and how the some of perhaps the most vulnerable touch points of service delivery for the person really falls at points of intersection between those Medicare benefits and those Medicaid services. And a really great example of that is care transitions, when someone experiences a significant healthcare change that crosses their needs. There's a way to treat that person in a kind of whole person integrated fashion that I think states that have invested in integrated models are really interested in building.
Great point. Lena, Community Catalyst has been engaged in efforts around integration of care for duals for several years. Can you provide us some background on the organization's role and work in this area? And then also from the beneficiary perspective, how should fully integrated care look for a dual eligible beneficiary?
Brings to the table in this area of work. And for those who may not know, we're a leading national nonprofit health advocacy organization dedicated to advancing a movement on health justice and health equity. So our mission is really, we want to build the power of people, create a health system that's rooted in race equity and health justice, and in a society where health is a right for all. So our work around the dually eligible population is really embedded in bringing their voices to the decision-making table, be it at the federal and state policy-making table, be it at the health system level, or at the individual level. And by really empowering their voices and experiences, we can make fundamental shifts into how Medicare and Medicaid work together. And so when we think about integration and what we think the goals of integration to be, my fellow panelists named a number of things that we agree with. And I think even building on that, integration should really be family-centered care. The engagement of community voices is essential to a success of a program. We think that centering equity in any system is critical. Thinking about things like cultural competency, linguistic competency, the types of materials that are available for members and family caregivers, including enrollment materials. And really understanding, and this is sort of a long-term goal, but this is really understanding the history, both the racial history of individuals who are dually eligible. As Tim mentioned earlier, half of this population are from communities of color. And then to have beneficiary protections, access to an ombudsman, things like continuity of care and integrated appeals and grievance systems. So, our framework comes from that perspective, and a bigger picture of what integration looks like. Those are some of the critical pieces that we care about.
Great, thank you. So we've heard now that integrating care really means going beyond financing. It's fully coordinated, person-centered care. It incorporates care management. It takes into consideration the beneficiary's experience of care, those care transitions, and it really takes into account community voices and is very improves the beneficiary experience overall. So now that we have a better sense of what integrated care means, let's talk about some of the integrated care models that are out there. This next question is for Pam. There are several different types of special needs plans. These include C-SNPs, I-SNPs, D-SNPs, High-D-SNPs, Phi-D-SNPs. So would you mind talking a little bit about the differences between all those plans and help us better understand all these acronyms that are out there?
I'll try. That's a tall task because there's a lot of detail. But the main vehicles have been the DSNPs out of the special needs plans. So they're a Medicare Advantage plans that Congress had set up to allow to focus on special populations. So the institutional SNPs, I-SNPs do just people in nursing homes, some of whom are dual. The C-SNPs do people with chronic conditions, some of whom are dual. But the main place for the dual eligible population to enroll and in Medicare Advantage and has where states have been involved, especially in trying to integrate care, have been what we call the dual eligible SNPs. And they're different from regular Medicare Advantage because they have to have models of care that are specifically designed to serve the population that they have enrolled, and that they can be, their enrollment can be confined to those groups, usually full and sometimes partial duals as well. They have these models of care are very extensive. They're set up by, they have to be approved by the National Quality Committee, NCQA, and they are audited and all of that. And the DSNPs are required to have a contract with the state, so they already have some kind of a relationship with the states, though that may vary across the nation. And then a subset of the DSNPs are what we call the fully integrated DSNPs, where they are held to some other standards of integration that are fairly long-standing, actually, and they need to coordinate care. First of all, they need to provide either long-term care types of services, LTSS services, or behavioral health, and in many cases they serve both. And the person is generally enrolled in two plans, one for Medicare, one for Medicaid, but those two plans are working together, perhaps usually under the same organizational structure. And then the high DSNPs is kind of another little add on to that, where they're not quite as integrated in terms of they also provide behavioral or long-term services and supports, but they may not be quite as integrated. Now, all of the DSNPs now, through Tim's efforts at MMCO and congressional requirements, have to provide some coordination between Medicare and Medicaid with what we call the integration requirements. They must follow up for appeals and grievances and things like that, and help coordinate whether or not they provide any actual Medicaid services. So, and that's an option. The states can choose to have these DSNPs to contract with them to provide some Medicaid services as well as their Medicare services, or not. So the state has some control over this contracting arrangement as to how broad or how narrow they want to have the relationship with the health plan that's sponsoring both programs.
Thank you for adding some clarity around all those different terms. Now, Tim, this next question is for you. Would you talk a little bit about the financial alignment initiative demonstration and where that fits in with some of those different integrated models that Pam just described?
Integrated care, as we've already kind of touched on, it exists on a continuum. It's not a binary, yes, you have it, or no, you don't. And in something that we call the Medicare-Medicaid financial alignment model, although many people just call the duals demos, we created a new class of health plan further down that integrated care continuum. A type of health plan that is subject to one enrollment process across both Medicare and Medicaid, one set of member materials, one benefit package, one unified appeals and grievance process, one contract with the health plan instead of two different contracts, one Medicare and one Medicaid contract, and a joint state and federal oversight process. Also, importantly, in that new class of health plan, everyone has to be in the same plan for both their Medicare and Medicaid services. An important distinction from the dual eligible special needs plans of which Pam spoke is that in many cases, dual eligible individuals are in a special needs plan, but they're in a different sponsor's Medicaid plans. You could be enrolled with Aetna for one product and Molina for another product. And so while it one of them might be called a dual eligible special needs plan. Hard to kind of understand how integrated that experience could possibly be for a beneficiary. So in these demonstrations, we created these products so that if you were in it, you were in it for your full suite of Medicare and Medicaid services.
Thank you so much. Now, Pam, building off of what Tim said, BPC decided to include improved FID SNPs as one of the options for states to choose a model of full integration. And these improved FID SNPs would incorporate some of the lessons learned from the financial alignment initiative that Tim just described. Why are FID SNPs well situated to provide integrated care to this population?
Well, I like that question. First of all, there are DSNPs in 47 states. So there is a platform there already. States already have some relationship with them. And as Tim said, it can be lighter weight, or it can be quite deep in terms of what kind of contracting relationship they have. But it's a big platform on which to build. First of all, and then second of all, the DSNPs, and particularly the FID SNPs, have the additional requirements that they have to meet, which are already set up to try to integrate and have been in place for quite a long time. As I mentioned, some of the operational things of coordinating care and working with the state, and they are moving toward coordinating grievance and appeals further, and a lot of the operational background noise that people have to currently navigate can be taken care of by building on those elements that are already there. And then we have a long history of working with DSNPs. They've been around since around 2006, and so some of the states do have a long history. So there's already been experience that people can look to see how it can work and how it can be built upon. There is the opportunity, as Tim said, they're not always fully aligned in terms of their enrollment, but the FID SNPs are more aligned in enrollment in terms of being in the same plan for both, or the same organization, at least for both types of services. So I think that it really makes sense on building on what the states have already been doing, where it's been moving, it's been growing. That kind of enrollment, FID and HIDE SNPs are growing. There's more interest in it. There's only a couple of states where it's not present already as a platform. So it makes sense to build on that infrastructure rather than starting all over with another infrastructure. And we can then take some of the things we've learned through the FAI demonstration, the alignment initiative that Tim was talking about. We can take some of those things, and we already have been pulling some of those into the DSNP world and trying to align the two models a little bit more, and make the DSNP platform more fully integrated. So it's exciting to see the focus that BPC has put on that, and with what the states need to further that is much of what they've talked about in this new report, which is exciting, because the states lack a lot of the Medicare experience and are eager for that if they are interested in integrating.
Great point. Building on some of what you said about states, this next question is for Alexandra. What are some of those barriers to states adopting and implementing these range of integrated models that are available?
Yeah, I think there's historically where barriers have been, and then kind of where they are today. And historically, there was barriers with program design flexibility, right? Not really any opportunities for states to share in savings that might accrue to Medicare. And so there's things in the past, right, that I feel are really the federal policy levers that are available to states that could kind of drive initial decisions around investing in integrated care that are really important, significant driving force for the progress that we've seen. But setting those more obvious barriers aside, or opportunities, if you will, at the federal level, when there are federal policy levers that can move states in the direction of developing integrated care models, there are still significant gaps in state capacity and ability to launch these models. I think this, starting with just the capacity piece, it really ranges from just securing staffing and really important system enhancements that are needed on the state side to be able to not just, operate your Medicaid program, but be able to have that effectively intersect with Medicare around enrollment and benefit design and all these different things that states need to do to operate these models. Pam made mention of needing to have Medicare expertise to be able to effectively design these programs and operate, whether it's a FIDE SNP or another program or model. There's a lot that states have to learn in the Medicare space, not just to perhaps launch or design the program, but over time to be able to oversee that integrated model and kind of understand how it's working to meet what the stated goals are for full integration. A couple other things I think that are real barriers for states is, whether or not there's actually a champion or a leader at the state level that's committed to improving coordination of care for dually eligible individuals. That, at least historically, has been something where without that, without that commitment and even someone you can point to, and I think Pam's an example of this in the history in Minnesota, but someone that you can point to at the state level that's really passionate and committed to keep integration efforts going and keep tabs on it has been something that states that have been successful have found and gotten out of the way if they needed to kind of keep that the resources for that leadership and that champion that's needed in place. The last thing that I'd share is another key barrier for states in advancing integration is just that it's not one size fits all answer, that the environment in particular states plays a significant part as well, that there are states where there is little or no penetration on a statewide basis of Medicare Advantage, or perhaps there's DSNPs in the state, but they're not available throughout a state. And I think that the state's own Medicaid managed care history, as well as experience they might have with supporting some of the more complex Medicaid populations that tend to be dually eligible, like those with the LTSS and behavioral health needs, those individuals may be carved out in state programs where there's a lot for a state to kind of learn to be able to develop what I think, I mentioned earlier, which is, a really robust care management platform, building on those federal policy levers and the carve outs in states, the landscape of health plans that exist in a state. There's a lot of things in that, kind of individual state environment, I think, that play a part.
Great point. And I definitely want to come back to some of those state level dynamics a little bit later in the discussion as well. So this next question is for Lena. With so many different types of integrated and non-integrated models that are available to beneficiaries, I want to discuss some of the challenges that this may create for beneficiaries. So Lena, what challenges do beneficiaries face in trying to navigate and understand this range of models that are available to them?
Yeah, thanks, Lisa. I think, and just building on one thing that Alexandra stated, one of the things we found in our research is using consistent messaging that resonates with this population. I think, in our policy world, we use terminology like care coordination and integrated care, and that's usually not the same terminology that beneficiaries are working with on an everyday basis. And so I think one of the roles for states, health plans, CMS is also to think about the type of messaging that that's out there so that people are understanding what their options are. But I wanted to share with the audience, and to your question, we talked to a set of dually eligible individuals over the past year and a half about what their experiences are about enrolling in integrated care programs, or why they disenrolled, or the reasons they opted out. And there were several factors that really rose to the top that I think are important to mention. One is, and may not be surprising to many on the panel and the audience, but the ability to continue seeing the providers they need to maintain their health. That was kind of the number one issue that that bubbled up consistently in all of the focus groups. The second one, when talking specifically about enrollment and enrollment materials, it's the opportunity for them and their family caregivers, or whoever is helping them to make a decision, to be able to make an informed decision after reviewing materials that are accessible to them. Sometimes, if they receive just one notice in a slew of other marketing materials that are coming at them, it's hard for them to really sort of sit down and say, okay, here are my options in front of me. I understand my options and I can make a decision. And so have, the ability to do that in an inclusive way is important. The other thing that, factored in was the opportunity to really speak with someone who's knowledgeable about integrated care options in their region or in their state and their locality. Ironically, when we asked the question about who you consider as a trusted source, is not usually the trusted source that's actually available on the ground to help them. And usually it's a provider who is providing guidance, or it could be a family caregiver, or many whom we spoke with, it's a local advocacy or community organization that they're really engaged with. And so thinking about that disconnect and giving them an opportunity to speak to someone who's knowledgeable. And another thing that came up pretty consistently in the focus groups that we did was the potential to receive additional or supplemental benefits. And that was really important. Things, like dental and vision, durable medical equipment came up quite a bit. And so I think all of those factors played a role in their experience into an integrated care program.
That definitely takes me to my next point. I wanted to talk about, despite the availability of fully integrated plans in most states, only about 12% of dually eligible individuals are enrolled in these programs. As you suggested, sometimes they opt out, and for a variety of reasons. And this next question is for Tim. From your perspective, what factors also might explain why enrollment in integrated programs remains low? What might be contributing to this?
Well, let's pick it up where Lena just left us. We can, as policymakers and workers in the executive branch, we can invent new programs, and they can be wonderful new programs. And even within that program, we can simplify the beneficiary's experience significantly. But that program still exists in a really dynamic, puzzling marketplace sometimes. And so our ability to simplify within a new model, within a new program, it will only take us so far unless we can simplify the overall experience of connecting with that particular program or initiative. So that's number one, and is profoundly important. Secondly, integrated care is just inherently state-based, as we've talked about so far. And let's face it, it's hard work. It takes a long-term focus. The fiscal case is kind of, this is tough for stakeholders sometimes to embrace, even for all the inadequacies of the status quo. Beneficiaries and providers and others are often scared of anything that disrupts it, usually because they have worked for decades in some cases to stitch together a system that works for them. So for all of these reasons, in addition to the fact, as Alex said earlier, we can't possibly overstate the complexity of running a state Medicaid agency. Every single year, that job becomes more important and more complex. And so it's really understandable that some state leadership hasn't invested all of the time and resource and energy to focus on new integrated care products when they have maternal mortality to worry about it, and just kind of an endless string of like other challenges of running an incredibly important complex insurance product. So while we want more and more focus, there are several kind of understandable reasons why this is a tough place for sometimes for state leadership and some of their local stakeholders to go.
Thank you. And I think you touched on some of the challenges of integrating care, but what are some of the benefits of integrated care for dual eligible? Could you talk a little bit about that as well?
Well, first, the challenges, I think, can be at least partly overcome by some of the work that we do and surely some of the recommendations in the BPC report. On our part, we have tried, I won't pretend that any of this is perfect, but we have created additional technical assistance infrastructure for states. We have a state data resource center to help states access and deploy Medicare data that we share on dually eligible beneficiaries. We have an integrated care resource center that helps states with policy development and work like that. And increasingly, we have tried to meet state leadership where they are. For some states, that's a big, ambitious, complex redesign of their system. For other states, that's a really incremental step towards better connections between, say, acute care providers in the Medicare program and long-term care providers funded through Medicaid. So I think it's incumbent on us a little bit in the federal government to try to work with our state partners to make incremental progress, even where it's not the right time for something more ambitious and complete. On the beneficiary side, what we know from years of experience now is that done right, we can significantly improve beneficiary experiences, and in many cases, improve health outcomes and independence in the community as well. We have a litany of studies now that show us that satisfaction rates are very high in well-run integrated care programs, that many have reduced inpatient hospital admissions, and more have reduced long-stay nursing facility admissions and improved access to home and community-based services. So where we can do all those things in an environment in which someone, when they need it, has an infrastructure of kind of care coordination and support, that's profound. Now, that's not everyone, right? They're just like in the general population, there are a lot of dually eligible beneficiaries who don't need in any given month or any given year some intensive, complicated support. But when they do, it's really essential that there's an infrastructure to help people. And no one was that more apparent during COVID experience, where time and time again, we found that in these integrated care contexts, we really had, I think, heroic calls to action to deliver food, to help check in on people, to help with social isolation during what was an incredibly challenging time.
Thank you. So we're hearing that each state is really unique and starting on the road to integration from a different place. And MMCO has taken some really important steps in helping states move toward integration through technical assistance and other types of resources they might need. So at the same time, there is at least 14 states and the District of Columbia have not fully integrated care and don't have those programs available to dually eligible individuals. And looking across states, some have made great strides in integrating care for dually eligible individuals, while others may be interested in integrating care, but are still in the very early stages of that journey. So to advance more equitable access to integrated programs across states, this next question is for Alexandra. What do states really need to move toward successfully integrating care for dually eligible individuals?
Yeah, it's a great question. And I think it's really interesting in the context of some of what Tim was pointing to in terms of resources available to states today. There really is today more support available to states in terms of technical assistance and targeted resources, support from MMCO, both federally funded and philanthropic investments that are really supportive, right, to what states need to be able to build these models. And I think that's been true over the last decade, and that there's a lot of demonstration of the value of that support to states. But I do think that there's a need, when you talk to states that are looking at moving in this direction or that have been through the development of integrated models in recent time, that there's, a need for additional support. There's also a need for like tailored and targeted support that states can kind of direct to where their own particular capacity, gaps, and needs are, to be able to effectively not just, build and design a program, but then kind of oversee it over the long haul, given the complexity and everything else that states are managing. And then I think that there is, a definite, just to not, I want to say shortchange the biggest, I think, thing that could propel more state investment, does map back to whether or not there is perceived or real value from the state perspective to develop, integrated care management models, and, some flexibility I think that states need to be able to adapt and perhaps take advantage of new federal policy levers, while recognizing the road for a state to get to fully integrated care, and what they again need to do it may be quite different, right, in one state versus another.
In a couple minutes, we will move to audience questions, but there's a couple questions I'd like to get to before that. Alexandra, do you think that all states will integrate care absent those additional federal supports in the forms of technical assistance or other resources, or would there possibly be holdouts still?
Two things come to mind. One is I'm curious what other folks on the panel might have to say about that as well. But I think it's a really easy question, but also a hard, difficult question to answer at the same time. I mean, the easy answer for me is based on the current landscape and the work that we've done over the years at CHCS with states, that, no, I don't think all states will integrate care based on, what the landscape of incentives and priorities and environments are in different states. But I will say that there's a ton happening in terms of incremental enhancements to DSNP programs, PACE expansions, all kinds of things, right, that there could be perhaps more incremental state movement. And then the unpredictable, or I think the harder thing for me to answer is, will all states move to integrated care? Is, if we think about how the landscape around us may change, which I know we know that does, I think that there are a lot of opportunities for us and everyone kind of engaged in this work, as well as states, to learn more about a population that people talk about as pre-duals, or individuals who are eligible for Medicare only, who might, from a state perspective, just be on the cusp of needing Medicaid benefits to a significant degree, including long-term services and supports, or perhaps enhanced behavioral health needs. And that there are a lot of opportunities for that landscape to change in terms of what might attract more states to building integrated care models, if there were perhaps, expanded access to things like home and community-based services on the Medicare side of the equation, that might incentivize states to really think about their dually eligible population and integrated care in new and expanded ways, and linking up to Medicare, because there'd actually be, potentially a support to states in doing that.
Great point.
Yeah.
And as you heard earlier today in the opening remarks, BPC believes that states truly are in the best position to integrate care. And in our new report, BPC recommends providing incentives for state-led integration efforts. And despite these incentives, for a variety of reasons, some states may still choose not to integrate care. And so BPC recommends that the HHS Secretary integrate care through a federal fallback program, and the federal government would recoup payments for enrolled individuals that would have otherwise been made to the state, similar to the approach taken in Medicare Part D for prescription drugs. So this next and last question is for Tim before we move to audience questions. While we understand that CMS has not taken a position on the federal fallback program, if Congress directed the agency to move forward with a federal program, what are some of the top considerations that CMS would have to make in that scenario?
If the law directs us to do something, we'll execute it to the best of our abilities, as always. The extent to which we can really successfully do in this context rests on a couple different factors. Obviously, one of them is resources and time to prepare, but another is the local infrastructure itself. I think some of the states in which we don't have a lot of integrated care action they are frontier states in which there are unique infrastructure challenges to delivering any care, much less integrated care. And then I think the really important question would be to what extent we can meaningfully engage with local beneficiaries and advocates and others to promote the kind of person-centered care systems that I think BPC envisions, and certainly we would as well. One of the things we have learned over the years is, the importance of working with people who are closest, and especially beneficiaries who are closest to the work that we try to do, and making that time investment is so important. And in any future legislation that involved this framework as it's laid out here, we'd want to make sure that we put in the investment so that we could work with the local folks and ensure that what we were doing was going to meet those local priorities.
Thank you so much. So now moving to audience questions. This first question from the audience member is, as Congress considers reforms, should additional requirements be added onto DSNPs to offer an aligned MLTSS plan, for example? Or should these requirements be on the MLTSS side? Or should there be state flexibility to choose? I'll open this up to any of the panelists to jump in.
I'll just say something here.
Yeah, I was going to say, I thought Pam might have a thought. Go for it, Pam.
Well, I think it would be, I think it needs to be more on the Medicare-Medicaid side and not so much just on the LTSS side. There are so many differences between states right now in their LTSS programs, and I think that BPC has already put out some suggestions earlier in an earlier report that I think are very helpful for states to look at to try to address some of those issues. But to try to get a state to completely revamp their LTSS programs at the same time you're trying to integrate care, I think would be kind of starting backwards. I think that states need to understand more about how Medicare decisions made in Medicare by primary and acute and subacute providers do affect their LTSS programs and how they affect the state's costs for LTSS. So it is important to start making those connections. But I think that we need to start a little bit, don't start trying to make the states completely redo their LTSS at this point.
Alexandra, was there something else you wanted to add to that?
No, I think that Pam's answer is sufficient. I'm sure there's other questions as well.
Great. And the next question is, would you all please speak to what financial alignment and incentives look like from a provider side? Would something like value-based pricing work in an integrated model?
I think Pam made a really important part earlier today, that financial alignment doesn't doesn't always mean that the beneficiary is going to have a seamless and holistic care experience. Often when we talk about financial alignment, we talk about it at the highest kind of governmental level between the federal Medicare program and the state and federal Medicaid program. And a classic example is if a state invests in new, say, behavioral health treatment, and the result of that is that fewer people are in the hospital, then those are savings for duly eligible beneficiaries that accrue to the Medicare program, because Medicare is the primary payer for that inpatient hospital. And when we think about financial alignment, so often we kind of put it in that governmental box. What we often do is just bring that down a level and try to capitate an organization through PACE or through health plans and kind of push down the level of alignment. That doesn't always solve things at the provider level, though, and that's an important piece for us to think about. There are some promising practices, but I still think we have a very long way to go. The cleanest example, I think, in many ways, is in the nursing facility setting, where nursing facilities have lower rates of pay for Medicaid days of ongoing care. They tend to have more highly profitable and much higher payment rates for post-acute Medicare days of stay. And that results in at least a little bit of a perverse misalignment of incentives, in which the more frequently a long stay nursing home resident is hospitalized, the more that nursing facility's revenue is maximized because they come back on a more lucrative post-acute care. That's the kind of incentive that, where we have kind of created an integrated care environment, we can start to fix through better contracting practices and payment policies with network providers like SNFs and NIFs. Again, though, while we have seen many examples, and often in the form of subcapitation to providers, we have a long way to go.
Those are some great points. Thank you. And it looks like we've reached time, so I will now turn it back over to Catherine Hayes in a moment for some closing remarks. I just want to reiterate everything Bill Hoagland mentioned earlier. We are incredibly grateful to Catherine Hayes for everything that she's contributed to BPC over the past several years. She has truly advanced the mission of BPC, and her work has made a meaningful difference for millions of Medicare and Medicaid beneficiaries. She will be incredibly missed, but we do plan to continue and grow her legacy through our future work. And I also want to thank Arnold Ventures for their support, and my BPC colleagues who also worked on this report, Eleni Salyers and Brian O'Gara. So last but certainly not least, thank you to our wonderful audience for tuning in. And Catherine, over to you.
Yes, and I would like to echo Lisa's thanks to the panel, to Ariel Mir, Amy Abner, and Arnold Ventures for their support of the health project. Again, recognizing Lisa, Eleni, and Brian for their work on this project. I'd like to thank Bill Hoagland and Jason Grimay and the BPC staff for a great 9 years. It's been a lot of fun. And also thanks to our leaders, especially Senators Daschle and Frist for their support, as well as Chris Jennings and Sheila Burke. Thanks to Henry Claypool for his guidance and friendship over the years. And I'd like to thank all of you for joining us today. Appreciate it. Thank you.